When an advanced practice nurse gets the authority to prescribe medication, it's so much more than just learning a new skill. It's a complete shift in who they are professionally. They go from following orders to writing them. So, what does it actually take to make that leap? We're going to break it down into 4 key pillars that support this huge responsibility. But before we get into the nitty-gritty, let's just pause on this one big question. What does it really mean to write a prescription? Because it's not just about scribbling on a pad, right? It's this profound act of clinical judgment, and it's all built on the trust between the person prescribing and the patient. And this really gets to the heart of it. It's this fundamental move from being a caregiver to being a decision maker. I mean, that is a huge leap in responsibility. You're going from being an expert at carrying out a plan to being the person who actually makes the plan. That changes everything about a nurse's role. Which brings us perfectly to our first pillar, really defining this new professional identity and understanding the authority that comes along with it. Okay, so here's where you see the real difference in their focus. A registered nurse, an RN, their clinical judgment is all about how the patient responds to a treatment that's already been ordered. But for an advanced practice registered nurse, or APRN, that focus shifts way earlier in the process. They're thinking about the diagnosis itself and then choosing the right therapy. That's a big deal because the legal buck stops with them on that decision. But here's the thing. This new authority doesn't exist in a bubble. The APRN is a vital part of a whole team. You've got physicians bringing their deep knowledge of disease and pharmacists who are experts on drug interactions. The APRN brings this amazing holistic nursing perspective, making sure the plan works for the patient's real life, often by being a fantastic patient educator. All right, let's move on to pillar number 2 and see how this all connects. We've got to understand the core science. This is really about the complicated conversation that's always happening between a body and a drug. The easiest way to think about this is like a two-way conversation. First, you have pharmacokinetics. That's all about what your body does to the drug. How it absorbs it, moves it around, breaks it down, and gets rid of it. Then, on the other side, you have pharmacodynamics, and that's what the drug does to your body, how it actually causes a change, usually by latching on to little receptors. You absolutely cannot understand one side of this conversation without the other. So how do drugs talk to the body? A lot of the time, it's through these receptors. An agonist drug is like the perfect key for a lock. It slides right in, turns, and fully flips the switch on, doing exactly what the body's own molecules would do. And then you've got an antagonist. This one is like a key that fits in the lock, but it just won't turn. It just sits there, physically jamming up the works, so the right key can't get in and turn the switch on. It's basically a blocker. And finally, there's this interesting middle ground, the partial agonist. This key fits, but it only turns the lock part of the way. So you get a response, but it's a much weaker one than you'd get from a full agonist. Think of it as more of a stabilizer or modulator for the system. So after a drug does its job, how does the body clean everything up? Well, that happens at the main drug processing plant, the liver. And it does this using something called the CYP450 enzyme system. Within that system, one enzyme in particular, CYP3A4, is a total workhorse. It metabolizes a huge percentage of common drugs. And check this out. Here's a great real-world example of why this stuff is so important. Grapefruit juice. Yeah, grapefruit juice can actually block that key enzyme we just talked about. So what happens? Well, it means some drugs don't get broken down like they're supposed to, and their levels in the body can creep up and up, sometimes even to toxic levels. It's a perfect and pretty common example of a drug interaction. So understanding the science, like how grapefruit juice can mess things up, is absolutely critical. But it's just one piece of the puzzle. So how does a prescriber take all this knowledge and actually pick the right drug? Well, that brings us to pillar 3. This isn't a guessing game. It's a systematic, evidence-based strategy. This whole thought process is really captured in these 6 steps. And it's not a straight line. It's more like a circle, a continuous loop. You define the problem, you set a clear goal, you pick the treatment, and you start it. Then, and this is so important, you educate the patient and you monitor what happens. That monitoring then feeds right back to the beginning of the loop, so you're always making sure the treatment is working as well as it possibly can. Now, when you're in the middle of a busy clinic, it's so easy to miss something. And that's why a lot of prescribers use clever little memory aids or mnemonics like this one. I can prescribe a drug. It's basically a mental checklist that makes them pause and think through everything. The indications, the side effects, the cost, the dose, all of it. It's a simple tool that helps make sure every single decision is as safe and complete as possible. Okay, and that brings us to our fourth and final pillar. You have to remember, every single prescription is written inside this complex web of laws, regulations, and ethical guidelines. The really important thing to get here is that there are two main layers of rules. It breaks down like this. The federal government, that's the FDA, they regulate the drug itself. They're the ones making sure it's safe and that it works. But then you have the state level, usually the Board of Nursing, and they regulate the person, the prescriber. They're the ones who say what an APRN is and isn't allowed to do in that state. And the FDA's approval process is intense for a very good reason. I mean, just look at this timeline. A drug can spend years in trials. It starts with testing in the lab. Then it moves into multiple phases with people. First just looking at safety, then seeing if it actually works, and finally testing it on huge groups of people. Only after all of that does the FDA even consider it. And even then, the monitoring never really stops. Now, for drugs that have a potential for abuse, there's another whole layer of law to deal with, the Controlled Substances Act. This system groups drugs into 5 different schedules based on their risk. Up at the top, you have Schedule 1 drugs like heroin, which you can't prescribe at all, and as you go down to Schedule 5, the risk of abuse gets lower, and the rules for prescribing get a little less strict. So, let's bring it all home. What does it really take to be a responsible prescriber? It all comes down to bringing these 4 pillars together. It's not 4 separate things, it's one complete picture. It starts with embracing that new professional role as a decision maker. Then you have to back that up with a rock-solid understanding of the science. You take that science and apply it using a smart, evidence-based strategy. And you do all of that within the boundaries of the law. It's this fusion of all 4 that makes a truly competent prescriber. I think this quote from the source material just says it all perfectly. This isn't just some technical skill you learn. It's a high-stakes mix of law, science, and good judgment, where the patient's safety and well-being has to be, without question, the #1 priority. And that kind of leaves us with one final thing to think about. I mean, the rise of the APRN prescriber is such a clear sign of how healthcare is changing, how it's evolving. It really makes you wonder, right? As these professional roles keep growing and expanding, what's the next big shift? What new decisions will be on the table next?